Hello, I'm Prithviraj Bose from the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. And we are here at the third international workshop on MPNs and MDS in Lisbon, Portugal. I'm joined by my colleagues Donal McLornan and Haifa Kathrin Al-Ali. And we just completed two very interesting and engaging sessions on different aspects of myelofibrosis, and we will be discussing those.
So my name is Donal McLornan from University College London.
And hi, my name is Haifa Kathrin Al-Ali. I'm a hemato-oncologist at the University Hospital of Halle in Germany.
So Donal and Haifa, we just had two really interesting sessions, I thought. And in the first one, we discussed, we started with prognostic models for myelofibrosis, of which there are many, and Alessandro walked us through those really nicely. Lucia Macerova from my institution then covered cytopenic MF. I covered early MF and, maybe should we treat these patients, who should we treat and with what? And then you, Donal, covered the very complex subject, I think one that is not fully agreed upon, of suboptimal response. So why don't we start with you? What stood out to you in that session?
Yes, I really like the session overall, because I think it's for all of us in the field, we see that the prognostic models that we're using are constantly changing. And Haifa brought up a really interesting point for us. I mean, many of us in the area are using molecular enhanced models now across our patient age ranges, whether or not they're for intensive or non-intensive treatment. But actually, these are models that have been derived from patients from many decades ago in some cases. And also when we think about it, we should be thinking about dynamic modeling for patients on treatment. And I think, as you suggested, as a future thinking concept, we need models that are relevant to our contemporary practice today, and thinking about landmarking those models based on treatment responses. And I think, as we all know, we have the RR6 model looking at dose density of ruxolitinib, looking at spleen responses, transfusion requirements at 3 and 6 months, and how that is powerfully dichotomizing that cohort of MF patients as regards survival. And I think that's really what we need to apply across the field.
No, absolutely.
Absolutely. And I think we all realized, with all the open questions and the nice discussion we had, that MF is not CML, and that we still don't know so much, and we have to learn. Yet I think the future is also brighter for the patients because of all the developments which we then discussed in the second session.
Right. And again, going back to your point about response to treatment and how we should, or the lack thereof, and how we should incorporate that into our prognostic modeling, right? So the RR6 is so far the only such formalized effort, but do you think we should be incorporating that into just our frontline disease stratification, of course, by definition means before treatment, and that's where all our models have been developed. But how would you, let's say, incorporate that? Would you use like the 6 months like the RR6 has done of ruxolitinib, or do you have
Absolutely,
any other?
Absolutely. I think this is really fundamental. And with all the available drugs coming, and as you said, also second line, third line, how long should I treat? So I think something like the RR6 model is quite helpful, not only within clinical trials, but also, in everyday clinical work. Whether this is the ideal model, I think it's our duty to, generate the data. But I think, we have to, I always say the response to treatment, the dose patients can tolerate of not only JAK inhibitor, I think of all medications, even in other diseases, it's the same situation, and the response. And I think, anemia and the impact of anemia, is it really still so bad under the new treatments? We prevent now, some of these drugs could prevent patients from becoming transfusion dependent, or even patients that are transfusion independent are turning back to transfusion independence. And the weighing of anemia versus transfusion dependency, I think, needs to be incorporated in all our predictive models, particularly with younger patients, transplant, because we still have, it's not that easy to send patients with immobility and mortality we still have. And so, we need to improve our stratification.
Right. You remind me with momelotinib, as I was showing in actually the next session that we just did, where there is data that if you make them transfusion independent, or if you improve their hemoglobin from below 10 to over 10, that could have an impact on survival, to your exact point. And Donal, just coming back to you, so you touched on a complex subject of suboptimal response, which every trial has defined differently, and then there is a lot of overlap between suboptimal and failure, right? So what do you think? Shall we ever have a consensus on this?
I think really when we were talking about suboptimal responses, we all know, I think we definitely need a working definition for us that's clinically relevant across our practices, whether it's a tertiary or community practice, because I think we know from emerging data that early identification of someone who's not going to get a durable response, whichever JAK inhibitor we use up front, we should be thinking about early intervention, in my perspective, to change. And I think that's where that suboptimal response versus it's probably easier to diagnose your primary refractory patient to your JAK inhibitor, much more difficult on a day-to-day basis to do that with a suboptimal responder, but clearly they're going to get a less durable response, not often good dose density of the drug. So I think we need to collectively as a community formulate probably a working diagnosis that changes over time, that's probably product specific as regards the JAK inhibitor and which line we use it. And that sounds complex, but I think moving forward to get the best responses for our patients, we need to do that.
And maybe it would simplify our trials if all could use the same definition of suboptimal response or failure.
Exactly.
Like for anemia, we are now maybe moving towards that. There was a paper last year in Blood that sort of tried to make uniform the eligibility criteria for anemia trials, yes, and the response criteria for anemia as well.
Right. I always give the example, this overlap, as you said, as you mentioned as well, between suboptimal, refractory, resistant patients, loss of response. And I think it is particularly with the combinations that are emerging to identify the real suboptimal, and maybe these are the patients who are likely to benefit most from add-on strategies with whatever, compared to patients that are truly refractory, resistant, because the idea, from all other diseases is not to wait until patients become refractory, but to try to go upfront.
Early
on. The question is always in MF, what is upfront from the very beginning,
right,
or at the suboptimal? So the suboptimal is really a very important issue we still have to solve.
I agree fully, and I think to link the two things we've talked about so far about prognostication, which is a snapshot of a signature up front in a treatment-naive group, versus then defining suboptimal response. One of the things we need to do is dynamically monitor clones, whether it's driver or non-driver, and maybe build that into the models as well. If we're seeing a strong percentage reduction in a driver clone, that's clearly a more optimal response, versus if we're seeing something much more sluggish or no response, should that be built in? Because I think in our younger patient population, that'll help us think about when we intervene with a combination strategy, when we think about more aggressive therapies.
Right. So, it's a nice segue, Haifa, what you just last said, into our second session where we had separate talks on Pelabresib by Adam Mead, Navtemadlin by yourself, Selinexor by Claire Harrison, and I provided an overview of the approved JAK inhibitors. So let me start with you. With the Navtemadlin, it has such a unique trial design, right? First time ever in the field, 600 patients, ambitious trial, but really very logical, I think. They're all going to start with RUX, and only if they are suboptimal for both spleen and symptoms do they then randomize to Navtemadlin or placebo. Your thoughts on this, especially as it compares to other drugs which are being developed more in the front line?
I think it's a very nice and a new strategy, challenging. We as academia definitely could not do such trials, but I think this is the right way to learn. What are the patients? And even we can then maybe indirectly compare, in this trial, patients have at least 18 weeks of treatment with RUX, and we could, then really maybe define what is definitely a suboptimal versus optimal versus refractory patient. Yeah, I like the design. I think it is challenging. 600 patients, it's not a joke.
So maybe identify truly who needs the second drug, right?
And I think it will make maybe the basis for future combination therapies and the definition of suboptimal, yeah.
Now, we also had a lot of discussion about Pelabresib. Obviously, this is the one where there is a completed phase 3 trial as opposed to, say, Selinexor, where we don't know the results, and Navtemadlin, which is a lot more early. So with Pelabresib, something that came up quite a bit was the leukemic transformation. And certainly, it was a bit unexpected, it was surprising and concerning. But at the 72 weeks at EHA, Alessandro Vanucchi showed us that the difference between the arms is narrowing. It is coming down. Now, I found that reassuring. You guys' thoughts on this important topic?
Yeah, I mean, I think like all of us in the field, we were quite alarmed when we first saw that signal with the combination of Pelabresib and the backbone of a JAK inhibitor. But I think the 72-week data for me is much more reassuring that we're not seeing this strong perpetuation of transformation risk. And I'm thinking about, because that for me biologically at the start didn't make sense. But why, when we're using this synergy, are we seeing this potential increase in transformation? But I think the long-term data is reassuring.
It is, but still it is worrying. The early signal is worrying because you are getting, early AML transformations, and we don't know why, particularly always considering that 60% of the patients were intermediate 1, not advanced disease. So sure, it is reassuring, but we have to learn and understand, and we don't have an answer yet to the reason why these early increases in leukemic transformation occurred in the combi arm.
Right. And also, Haifa, let me go back to this. I know we touched on it, but you said a couple of times during the session that if it's fair to put it this way, that you're more a fan of the add-on strategy than, say, going with the combo up front. Your overall thoughts on that, like what makes you think that way?
And we, as you said, we discussed this. What is the endpoint? What do I want to achieve with an add-on from the very beginning? It is always, combination. We all know JAK inhibitors, particularly ruxolitinib, has particular adverse events, particularly the hematological adverse events. We need the dose modification in almost 70% of our patients, and we do all this stuff within the first 3 months. And if I put another drug from the very beginning, we reduce both or we stop, I don't know. We don't really know what we're doing, and we don't know what is the aim. And that's why most of our patients are elderly, they have comorbidities. So maybe we are putting the advantage we know from a strong drug like Rux at risk for something with a very, very big question mark.
If dose reductions are necessary.
Dose reduction, discontinuation, yeah.
And I also agree, and I think obviously clearly with focusing on the clinical endpoints with this sort of strategy, but also the translational work that will come off from having that JAK inhibitor period lead in, then the combination thereafter, because that's a very different combination situation than starting both drugs up front. So I really like that with the emergent translational work we'll probably see with the immune repertoire, with the clones, etc., with that lead-in approach.
I think the Manifest 2 was probably informed by the Arm 3 of Manifest, where they saw some amazing spleen and symptom responses by starting at both together, and that's probably what just led to the Manifest 2. And then the Selinexor trial, Sentry, has sort of followed suit. I guess the leap of faith here is that if you get a deeper spleen response and symptom response at week 24, that will translate in the long term to greater benefits. But we don't know that.
And not yet seen with Manifest 2.
Yes.
We don't have a survival benefit.
Not yet, correct.
Yeah.
Well, very engaging sessions. Thank you both so much for your insights.
Thank you.
Thank you.